Good morning, everyone. Good morning, everybody, and thank you for joining us this morning. My name is Anne Fazakali, and I'm the Head of Philanthropy at the Bionics Institute. And it's my great pleasure to welcome you to our Rethinking Rheumatoid Arthritis Event. I'd like to give a special welcome to our Chief Executive, Robert Klupax, board members at the Bionics Institute, Brian Jamieson and Roger Gillespie, and also the Chair and Chief Executive of Neo Bionica, Lucia Guthrie and Ludovic Labat. Also a special welcome to Brenda Shanahan AO, who is the Chair of the Aikenhead Centre for Medical Discovery, of which the Bionics Institute is a proud member. I'd like to acknowledge the traditional custodians of country throughout Australia and their continued connections to land, sea and culture. I pay my respects to their elders, past, present and emerging, and I extend that respect to all Aboriginal and Torres Strait Islander people in Australia, and indeed to all First Nations peoples, as we have several visitors from overseas joining us this morning. So before we begin the presentations, let me mention some housekeeping items. Please try and keep your microphones muted throughout. If you have any questions for our panelists, please post the questions into the Q&A function screen, and we have a Q&A section at the end of the presentations. So we're really delighted that you're joining us this morning for this presentation session on rethinking rheumatoid arthritis. We'll be providing the latest information on rheumatoid arthritis and the current treatments, remembering this is a condition that affects an estimated 200,000 people in Australia alone. We'll update you on the pioneering research that we're undertaking at the Bionics Institute, and we'll discuss the amazing impact that this research could have on the future treatment of rheumatoid arthritis. And finally, we'll share with you some tips and guidance on how hand therapy can support treatment for this condition. So today you will hear from three specialists: Dr. Evange Romas, Head of Rheumatology at St. Vincent's Hospital here in Melbourne, and our clinical partner in this programme, Dr. Sophie Payne, our lead arthritis researcher at the Bionics Institute, and Nick Antoniou, occupational therapist, accredited hand therapist from Nick Antoniou Hand Therapy. So first, let me introduce Associate Professor James Fallon, who will tell us more about the work of the Bionics Institute. He holds a Bachelor of Engineering and a PhD in Biomedical Engineering from Monash University, and he began his research career with us at the Bionics Institute in the Auditory Neuroscience Programme. He's been our research director since 2017. He's a leader and a mentor to our team of researchers, and he's a holder of several patents. James.
Thank you, Anne. Welcome all to the Bionics Institute. Many of you may be wondering how the Bionics Institute has gone from its foundation 30 years ago by Graham Clark in trying to invent the cochlear implant to trying to develop treatments for rheumatoid arthritis. One of the key things Graham did all those years ago was realise that if he could get electrodes in just the right spot and deliver small amounts of electricity to the ear, he could restore hearing. That was one of his great insights. One of the other great insights he had was that you actually need a team of people to be able to do that. He brought together engineers, physiologists, other scientists, clinicians, patients, all working together to develop that technology. No one individual could do it by themselves. Since then, the Bionics Institute has continued in that same spirit of groups of people from different disciplines working together to take that concept of using electricity to activate different parts of the body. We've developed the retinal prosthesis, returning sight to the blind. We've improved the way that we can stimulate the brain with deep brain stimulation to help improve Parkinson's disease. And more recently, we have started to look to see if we can use electricity to stimulate the body in other areas to help treat conditions that have typically been treated with drugs. And that's where we're at the moment. In fact, we were sought out by the United States government to start to develop one of these therapies to try and treat inflammatory bowel disease, which covers Crohn's and colitis. They sought us out from worldwide because of our expertise and our collaborators at the University of Melbourne and the Florey Institute to develop a new electrode array and a new device to be implanted on the vagus, which you'll hear a lot more about later from Sophie. And that device is hopefully entering clinical trial later this year. And it's from that device and the innovations we've achieved from that Sophie and Evange have been able to develop the devices you'll be starting to hear about later today. So thank you all for coming, and I'll hand back to Anne now.
Thank you very much, James. I'd now like to introduce Dr. Evange Romas, our clinical expert and partner on rheumatoid arthritis. Evange is head of the rheumatology unit at St Vincent's Hospital here in Melbourne, and he's an associate professor at the University of Melbourne. He's also an honorary fellow at the Bionics Institute. For the last 25 years, he's undertaken research on the mechanisms of joint destruction in rheumatoid arthritis, and he's participated in landmark clinical studies on targeted therapies for rheumatoid arthritis. In his presentation today, he'll review rheumatoid arthritis, the disease, he'll discuss current therapies, and he'll talk about unmet needs in rheumatoid arthritis. And he will also introduce the anti-inflammatory reflex, which is mediated by the vagus nerve. Evange.
Thank you, Anne. So there was a time not too long ago when we were unable to see patients early, we were unable to diagnose them accurately, and we were unable to treat them effectively. And exactly how we achieved a complete rethink for a disease that was previously regarded as untreatable is actually a remarkable project. So rheumatoid arthritis remains incurable, but also highly treatable. It's a symmetrical inflammatory arthritis that persists for years with no tendency for spontaneous remission, which sets it apart from many other types of arthritis. We can measure the inflammatory process by tracking blood tests for substances such as C-reactive protein and measuring the ESR. And these measures reflect the overproduction of inflammatory cytokines that's occurring in the joints and systemically. The autoimmunity in rheumatoid arthritis is reflected in the elevated levels of rheumatoid factor and highly specific antibodies to altered proteins, which are called anti-CCP antibodies. These are proteins to citrullinated proteins in the body that occur for various reasons and are highly specific markers of the disease. These antibodies don't cause the disease, but probably amplify the inflammatory response to cause damage, and they're associated with chronic pain, functional and work disability, loss of quality of life, and it also causes accelerated coronary artery disease and increased mortality if it's untreated. Past obstacles that we had to contend with were false perceptions that nothing could be done, that rheumatoid was not life-threatening, unlike certain other diseases. We lacked the tools. We really didn't know what was the correct thing to measure. We now know that measuring swollen joint counts and tender joint counts and combining these measures with appropriate blood tests such as the C-reactive protein and getting what we call composite measures of disease activity is highly useful. And we've realized from insights with better and more sensitive imaging how effective it can be to track patients with sensitive ultrasound and MRI imaging in selected cases. Cortisone was a useful drug that caused side effects, and we couldn't manage these side effects because we didn't have the treatments for osteoporosis, and we didn't know the right dose of cortisone to use. We had no reliable treatments to stop joint damage like we do now. Treatments such as Methotrexate, the TNF inhibitors, and small molecule targeted therapies that we'll talk about. So one of the other obstacles is that once rheumatoid arthritis has momentum, it's very hard to stop. Damage occurs within months and is relentless. The disease actually becomes biologically more complicated the longer it lasts. It becomes a different disease with each passing year. This also makes it a lot harder to treat. Damage occurs fast and within months of first symptoms. And here's an MRI from a patient showing the bone erosions, the structural damage time when the patient had a swollen wrist and a tender wrist, had difficulty using the hands, but the plain x-rays at this stage showed swelling, but were unable to show damage, creating perhaps a false perception that not much was happening. If we look at patients as the arthritis progresses, we see periarticular bone loss around inflamed joints. The joints that are typically inflamed in rheumatoid are these at the metacarpophalangeal joints and the interphalangeal joints. We also see cartilage loss that reflects loss of cartilage, the joint space narrowing here, and the characteristic bone erosions in persistently inflamed joints. And these are the hallmark feature of severe seropositive rheumatoid arthritis. And in general, patients with erosions, when we see them, are more difficult to treat. They can achieve a low disease activity, but less often they can achieve remission. So early and aggressive treatment is needed to prevent this damage. Now, before the 1980s, rheumatoid arthritis was treated with aspirin, anti-inflammatory tablets like indomethacin, gold injections, or penicillamine, and sometimes these treatments worked, but usually they made patients sick, and patients couldn't take them for very long. We had weaker drugs like hydroxychloroquine, and of course we had cortisone injections, but this was really the era of despair. While Wall Street misbehaved, something remarkable though was happening in rheumatology. Methotrexate emerged as the first treatment that really made a big difference to patients, and methotrexate was a treatment that was developed for leukemia in the 1950s and was rediscovered and redeployed for rheumatoid arthritis. And we call drugs like methotrexate disease-modifying drugs because they can actually modify the outcome of rheumatoid arthritis, and they can sometimes prevent damage. So here's one of the first studies from Boston that showed improvement in arthritis within 3 months of methotrexate therapy. And you can see here the joint severity index that they used at the time. Patients given methotrexate within several months had a remarkably reduced joint in pain index and inflammation index compared to those that got the placebo drug. And then in 3 months, the groups crossed over and the methotrexate patients got the placebo and they promptly reverted back to their baseline. And the patients on placebo were given methotrexate and they improved. And in some patients, these erosions that were seen, if they maintained methotrexate therapy for a long enough time, they could actually heal. And it was one of the first times, although this was seen with gold on occasion, very rarely, it was one of the first times that we could consistently see good disease suppression enough so that the joint could heal. So this was remarkable for a chronic disease. Methotrexate was easy to take, it was taken once weekly, it was well tolerated. We learned how to use folic acid to make it better tolerated, and patients can take it for a long time. If you have a disease that lasts for many years, if you can take a treatment for a long time, it can make a big difference. Now, one of the problems is that if you treat methotrexate, and there are a number of studies, and this is perhaps the purest of them from the Netherlands, we can show that it makes a huge difference when you start. So this is comparing patients who started methotrexate within 2 weeks of onset of arthritis compared to those where the ship sailed a bit later at 4 months. And you can see this is the change in bone erosion over 2 years, that the patients that were treated early maintained minimal levels of joint damage compared to those that started just a few months later. So it's like, you missed a window of opportunity if you delay treatment. And this was a very important insight. And studies like this led to the concept of this window of opportunity early in the disease, when it was perhaps biologically more simple and easier to treat, and really was a very important step in the treatment. So as good as methotrexate was, in the clinic, we still had a problem. Patients would come in with swollen hands and joint stiffness and pain. They had disability. We treat them with methotrexate, and within a year, they'd look something like this, with less joint pain, less swelling, and improved function. And we think we're doing okay, but then as we follow them, typically they see someone different in each time in the clinic. Something like this occurs when the head of rheumatology comes along and finds this, having remembered the patient like this 7 years earlier. So there was a problem. What's going on here? So the insight really was gained with better imaging. With better imaging, it was soon clear that the reason was that DMARDs such as methotrexate can produce a clinical remission, but they rarely produce a deep imaging remission. Therefore, DMARDs such as methotrexate, our conventional DMARDs, rarely produce what we consider to be a true remission. And this explains the progression of damage that we see very often in patients who appear to be in a clinical remission. And this was an unmet need at the time. So how was this unmet need addressed? Well, if we delve into the biology of the joint, and now this is like Fantastic Voyage, where right inside the joint, here's the bone, the cartilage, and the inflammatory pannus. An immunologist identified a myriad of cells that were relevant, including antigen-presenting cells and T cells. They worked out how these cells were activated, how they interacted with B cells and plasma cells, and the macrophages here. There are a number of soluble mediators that we call cytokines that can serve as communication agents between these cells. This cell is very important because it pumps out molecules, cytokines such as TNF and IL-1 and IL-6, and is responsible for orchestrating much of the damage along with others. And it was very hard to pick a winner out of all this. And it was really through elegant science and trial and error and animal studies that the way forward was seen. And in fact, early on, TNF was a cytokine that seemed a likely suspect because it was made by activated macrophages, which were very plentiful in the joint, which stimulated other cytokines such as IL-6 and IL-1. It released prostaglandins from other cells, which are to do with pain and inflammation, and it's the molecules that aspirin and anti-inflammatories can block. It affected bone cells and cartilage cells to promote joint destruction. So it looked pretty suspect and was a good target to go for. And this heralded the era of biologics, which we term targeted therapies. Now, biologics are gigantic molecules. Typically, they're monoclonal antibodies, and they're called biologics because you can't make them in a laboratory, no matter how clever you are, no matter how much tools you have, what reagents you have. If you don't have cell culture, you can't make antibodies. So this is why we call them biologics. And over the years, we've developed biologics that neutralize TNF-alpha and neutralize other targets, such as IL-6, and affect B cell function and T cells. Just for you to know, these are big things. And if it's like, a small molecule like Celebrex is like a teacup in your hand, and your house or a bigger building is this molecule, and the business end is right here, where it binds specifically to its target and it neutralizes it. So if you inject this substance, you can neutralize and overproduction of this substance, and therefore do some good things in arthritis. We have newer drugs, which are small molecules, which are also called targeted therapies, but they're not biologics, because if we give the correct reagents to a clever chemist, they can make these small molecules in the laboratory. And these include the JAK kinase inhibitors, of which we have several now that we're using in the clinic. So this was a remarkable achievement, as seen here. These are patients from the Kennedy Institute that were treated with infliximab that blocks TNF. These are patients here with methotrexate therapy, and they're not doing well, they're not responding. If you treat them with infliximab, you see substantial responses here in blue, and even better responses if you add infliximab to methotrexate. So this was kind of a revelation, and the revelation was confirmed by the sensitive imaging that was being developed at the same time, showing that with a TNF inhibitor, so from this baseline, this is the joint swelling here, the residual joint swelling, you could actually achieve something like this to minimize joint swelling and prevent joint destruction. Now, we know from our studies that the harder we knock down inflammation, the better the results in terms of preserving the joints. And this is shown here in a study that looked at patients. This is the disease activity score, higher disease activity, higher damage, less disease activity, less damage over time. This is with methotrexate. If you add a TNF inhibitor to methotrexate, you can improve this remarkably and uniformly prevent joint damage, irrespective of any residual inflammation. Now, of course, these patients would much prefer to be like this, because if they have inflammation, they typically will have symptoms and pain. So although biologics do uniformly stop damage, what we want is a treatment that can improve symptoms, quality of life, and stop the damage. And to a large extent, these treatments do that, but there are some exceptions. Now, in rheumatology, we talk about ACR responses. And what does this mean? These American College of Rheumatology. Well, it sort of refers to the degree of suppression of arthritis. So if you have a 20% reduction, you have what's called an ACR 20. Now, an ACR 20 needs a rheumatologist to detect a difference. An ACR 50, where there's a 50% improvement, a medical student can pick that level of improvement in the clinic when they visit us. An ACR 70, your neighbour knows that something's different about you, that you're moving better and that you're feeling better, and other people can notice a difference. So with methotrexate, in early arthritis naive to treatment, we can see about 25% achieving this very good low disease activity response. If we add TNF inhibitor, we can increase that. Typically what we do in practice is we start with methotrexate, and if we're not able to achieve a satisfactory outcome, we add a TNF inhibitor. Now what happens, so this is what happens if you add it to people that are not responding to methotrexate. You can push greater numbers of people into this preferable state of being. What happens if patients don't respond to TNF? Well, they're a harder nut to crack. As we move along the right here, it becomes harder and harder to treat rheumatoid. We can use rituximab that blocks B cells, we can block IL-6, we can block other molecules to do with T cell function. And if we do that, we can get some responses. But as you move from patients that have never seen methotrexate to those that prove resistant to methotrexate, and those who are resistant to TNF, it becomes harder and harder to get an ideal outcome. So the problems that we have with targeted therapies is essentially that they don't always work. So there can be what we call primary failure. That sometimes there's secondary failure when the body produces neutralizing anti-drug antibodies. And this is one of the reasons we often use it together with methotrexate to try and prevent this secondary failure phenomenon, because these are proteins, they're large proteins, and the body thinks there's an invader and it makes neutralizing antibodies. So that's why we use methotrexate. There are patients who can't have them because they have some additional illness, such as they've had a history of lymphoma, or they've got severe heart failure, or they've got MS, and they can't have these drugs because they make those conditions worse, or they're contraindicated. And by far the most serious problem is infection, manageable, but if patients are older, or they've got a history of infection, or they've got diabetes, this can be a problem with the TNF inhibitors and other targeted therapies. So the unmet need is that about 50% of the TNF therapy experienced patients who are incomplete responders on TNF therapies can't achieve this ACR 70 low disease activity state, which is where they want to be to preserve their joints, to preserve their quality of life, and to preserve their work capacity. About 10 to 20% of patients prove resistant to multiple biologics. So what we need are new ways to knock down these cytokines that fuel the damage to the joints that doesn't involve these things, and is a sort of a fresh thinking type of approach to the problem. It's possible that vagal nerve stimulation may be the way forward, This is an anti-inflammatory vagal reflex that was discovered some years ago, wherein the vagus nerve, which is actually the longest nerve, one of the longest nerves in the body that connects the brain to the rest of the body, if it's stimulated appropriately, it can transmit signals to the spleen, where there are T cells, and those T cells can in turn inhibit macrophages and monocytes producing TNF and IL-6 and suppress a host of cytokines. And this is a very promising non-drug approach to manipulate the biology of arthritis for patient outcomes. So to summarize, the solutions that we come up with are to see patients early in that window of opportunity to provide access to rapid sort of clinics, to aim for a treatment target that maintains function and quality of life, and this is usually low disease activity for all patients, and it can be remission for those patients that don't have severe joint damage. We hit hard early using whatever it takes. We use methotrexate in combination with biologics. If a biologic doesn't work, we switch. We get creative. We treat to target. We adjust the therapy if it's not working or if it causes side effects. We can, in many cases, de-escalate and taper treatment when patients are stable, but it turns out that we can't stop the biologic therapy, because if we stop it, the arthritis returns, but we can substantially reduce it in many or most patients down to about 50% of their dose and maintain a good remission. And we have new ideas to knock down these cytokines, and the new ideas, the exciting devices that recall Ehrlich's magic bullets are these vagal nerve stimulators. And Sophie's going to tell us a lot more about that. Thank you for your attention.
Thank you very much, Evange. I think that has probably generated quite a lot of thoughts and questions amongst you. Please do put your questions into the Q&A session, into the Q&A box, and we'll review those questions and aim to answer them at the end of the presentation section. So I'd now like to introduce Dr. Sophie Payne, a research fellow and lead on our pioneering arthritis work at the Bionics Institute. Sophie is an alumna from the University of Western Australia with a BSc and a PhD in neuroscience. She's worked at the Bionics Institute since 2015, investigating the modulation of the vagus nerve. So we invite you now to hear more about our innovative vagus nerve research and how this work can help people who are living with rheumatoid arthritis. Sophie.
Thank you for that introduction, Anne. And I will just... Great. So in our body, we have nerves that connect our brains to our organs. All peripheral nerves send sensory information from the body to the brain and motor information from the brain to the body. The research that we do at the Bionics Institute looks at using the nerves in our body for the treatment of disease. Today, I will talk to you about an example of this research, which utilizes an incredible nerve known as the vagus nerve. The word vagus comes from the Latin to wander, and it does just that throughout the body. It starts in the back of the neck and contacts most of the major organs, including the heart and lungs, as well as the liver, stomach, and intestines. Well, what does this superhighway nerve actually do? Most of the vagus nerve consists of what we call sensory fibers that send information from the organs, such as the heart, lungs, and the gut, to the brain. For example, the vagus nerve also tells you how hungry or full you are. About 20% of the motor axons in the vagus nerve send signals from the brain to the organs it contacts. And one of the major roles it has is in controlling digestion. More recently, and Evange mentioned this briefly, scientists have discovered that the vagus nerve reports to your body on whether or not the body is experiencing inflammation. The vagus nerve is then able to control the body's response to inflammation, effectively acting like a natural, indwelling anti-inflammatory reflex. Just a little bit more information on that. So the body can experience lots of damaging inflammation when it becomes infected from a cut or wound, or from an autoimmune disease such as rheumatoid arthritis. When the body detects the presence of inflammation, it snaps into action by releasing immune cells that are made in the spleen. These immune cells then release inflammatory cytokines, which Evange went into detail about. These unfortunately cause the stimulation of even more inflammation. Even though it's really important for the body to have this defense against inflammation, this reaction can easily get out of hand and do more damage than good. But not to worry, your bodies really have thought of everything. So recently, scientists from New York have discovered a natural break in the body. So after the vagus nerve detects inflammation, it sends signals to the spleen to reduce this production in immune cells and to reduce the release of inflammatory chemicals. In diseases such as rheumatoid arthritis, something goes wrong with the immune system. However, activating this natural anti-inflammatory reflex can potentially help reboot the system. Electricity is everywhere in nature. The concept that electricity can be harnessed to treat disease is an ancient idea. Ancient Greeks used electric arrays, a type of fish, to treat gout and even numb the pain of childbirth. Can't quite get my head around that. Our own nervous system also uses a form of electricity to send signals around the body and to transmit information. In more modern times at the Bionics Institute, we are using devices to deliver electricity to reboot the body's anti-inflammatory reflex, specifically for the treatment of rheumatoid arthritis. In our modern world, we have found other ways to use electricity as a therapy that does not require the use of electric fish. I'm sure you'll all be very relieved to hear that. The activity of nerves can be altered by surgically implanting a device into the body and wrapping it around the vagus nerve at the level of the neck, so what we call the cervical vagus nerve. This electrode here is made out of platinum and is held in place using medical grade silicon, which is really compatible with the body. The array is connected via a cable to a stimulator that sits here in the chest under the skin, that generates the electricity that's required to increase the natural activity of the vagus nerve. This device is actually manufactured by a company called LivaNova and is used all the way around the world. So using this device, this commercially available device, a recent clinical trial has looked at the effect of vagus nerve stimulation in rheumatoid arthritis patients. So these patients that were involved in the clinical trial were effectively drug resistant, and they had not responded to the usual therapies available to them. However, after just 2 minutes of stimulation a day over a 3-month period, half of these drug-resistant patients had improved symptoms, that being they had a lot less pain, they were able to move their joints a lot more easily, and their circulating inflammatory chemicals in the blood were reduced. This is an absolutely fantastic result, but there's a drawback. Although it is promising, there is a major drawback to stimulating the vagus nerve in the neck level. As you can see, the vagus nerve also connects to many other organs, such as the lungs, the voice box, and even the heart at this level, as well as, of course, the spleen, which is what we want it to connect to. So when the cervical vagus nerve is stimulated, unfortunately, patients experience what we call off-target effects or side effects to the stimulation. And these include coughing, hoarseness of the voice, numbness, and most alarmingly, slowing of the heart. Not only are these symptoms unpleasant, but it could also limit how long and how much therapy is delivered. So now I'm going to describe our new exciting technology and what are we doing differently? Well, the first change is that we are using a different location in the body. Essentially, we are targeting the abdominal vagus nerve which is in the abdomen and resides below the branches to the heart and the voice box. So when we stimulate this part of the nerve, we avoid stimulating the heart and the lungs and the voice box. So patients will no longer be experiencing coughing or slowness of the heart, which are experienced when you target the neck. We've also completely redesigned the array, as you can see here. You can see that we have more electrodes, which means we are not only able to stimulate the vagus nerve, but also record from it as well. Why does that matter? Well, this means that we can 100% confirm that patients are getting their electrical therapy. And believe it or not, most devices don't have this feature. In fact, the only way you can tell if the device is working is if patients are experiencing side effects. So hopefully this solution is much more safe for the patients. So what will this technology look like in our patients? We do believe that our therapy is most appropriate for drug-resistant patients with arthritis, at least for now. The device will be implanted into the body, shown here, and this is an example of what it'll look like, using keyhole surgery, which will take about 60 to 90 minutes. The stimulator will be placed under the skin at the hip level, just below the belt line. All patients recover from surgery, and eventually the device will be switched on and set at a certain level by a clinician and forgotten about. The device will deliver the electrical therapy in the background without the patient noticing. Patients will, of course, still keep in close contact with their clinician, and if required, the dose of therapy adjusted using a computer. This concept of being able to set and forget about your medication is a huge benefit of this kind of bionic therapy. Imagine knowing that your body's natural anti-inflammatory reflex is being stimulated automatically for you. You don't have to remember to take anything or to press a remote, and even the batteries are going to be replaced every 10 years or so. So all you have to do is set, forget, and your bodies will do the rest for you. This project is a new one at the Bionics Institute, and despite a world pandemic and me disappearing off to have my first baby, it has been fast-tracked into where it is now in just under a year. And that is all down to the amazing team that I work with at the Bionics Institute. Our next steps are to start the ball rolling for a clinical trial. We are fortunate that our device has already been approved for a clinical trial to treat another disease, that being Crohn's disease. So we really do hope to see the start of a clinical trial, hopefully in a few years' time. Thank you.
Thank you very much, Sophie. I'd now like to introduce Mr. Nick Antoniou. He's a graduate of La Trobe University, and Nick is an occupational therapist specialising in hand and upper limb rehabilitation. He has a postgraduate diploma from the University of Derby in the UK, and he's recognised in Australia as an accredited hand therapist. He's worked alongside some of Melbourne's leading upper limb surgeons, and he has a collaborative approach to treatment in close consultation with both patients and doctors. So Nick today will speak to us on a specific approach to treatment for arthritis. Nick, over to you.
Okay, thank you, Anne, and thank you to everyone at the Bionics Institute for having me here today. My name is Nick Antoniou, and I'm an occupational therapist that's working in the area of hand therapy in private practice here in Melbourne. And today I'll be explaining the role that hand therapy can play in assisting and benefiting people who have rheumatoid arthritis. So firstly, a few words on hand therapy. Many people will often say to me, I've never heard of hand therapy, and it's something that many of our clients and our patients will commonly say to us, that until they've been referred to a hand therapist, they'd never basically heard of one. So the definition really across many hand therapy societies across the world is that hand therapy is the art and science of hand rehabilitation of the upper limb. So essentially it is the physical therapy, if you like, for the hand, wrist and elbow. But as you can see, and as you will see, it is really more than just a physical therapy. So hand therapists are either occupational therapists, like myself, or physiotherapists, and these are probably professions that most of you are probably a little more familiar with, and they have done further training and specialisation in the area of upper limb rehabilitation. And OTs, I think in particular, through their undergraduate training, are really well placed to recognise occupational dysfunction or activity dysfunction, and also how to intervene holistically, given that the underlying philosophy of occupational therapy is premised in managing dysfunction and dysfunction in occupation. Our peak body is the Australian Hand Therapy Association, which provides essentially a mechanism for accreditation, which is a credential that requires a high level of education and clinical practice. And most hand therapists like myself will be working either in private practice, and a large number of us are also working in public hospitals, and to a certain extent in community settings as well. So what do hand therapists do? Well, we do many things. We provide education and advice on the conditions and injuries that we are treating. So a comprehensive evaluation and assessment is a really big part of what we do. And that's because we don't have any fancy imaging or investigations that we can actually use. So we're very often relying on a complete clinical assessment to determine what is going on. And that is done through a range of different clinical tests that we may use. We can look at muscle systems and sensory systems and to evaluate fully what is going on. We evaluate pain and their triggers. And of course, we evaluate dysfunction and what factors may be causing it. Of course, then comes treatment, whether it be exercises to facilitate movement and strengthening of the hand, wrist and elbow. And scar management is also another big area that we actually work in. And of course, splinting is probably one of the mainstays of our treatment. And that's where we prescribe and we fabricate splints or orthoses for various reasons. Next slide. Okay, so specifically when it comes to the condition of RA and its impact on hands, I'm sure many of the audience members will probably be able to tell me a little more specifically some of the main features of rheumatoid arthritis and how it can express in the hands. As we would imagine, the presentation is often very nuanced. So the person next to you with rheumatoid arthritis may have a very different set of a different presentation in terms of in their hands. And that's fairly typical when we consider just the various types and subtypes of the various rheumatological conditions. And a further point, I suppose, is when we're looking at x-rays, we can only tell half the story a lot of the time. Because very often the pain and dysfunction does not always correlate with radiographic findings. One of the things that we can see with rheumatoid arthritis generally though is we have pain and swelling. So we have painful and swollen joints at different times, and these can fluctuate depending on the level of disease activity that a patient has. We can have stiffness in joints, and that can often be variable as well, often worse in the mornings or after a period of inactivity. We can have dysfunction. So 70% of patients who have rheumatoid arthritis will report reduced hand function. Now, that can be whether it's directly related to the joints themselves or due to some of the indirect effects of rheumatoid arthritis on function, such as, for example, fatigue and tiredness. And we know that 40% of patients with rheumatoid arthritis will report other non-joint symptoms. So, of course, all of these will have an impact on the day-to-day function. So joint deformity, that was mentioned a little earlier as well. So that can often be very often seen with people who've got rheumatoid arthritis, and particularly with long-standing disease. We can see that, I guess, that has probably declined over the decades. Certainly in the 2 decades that I've been working in hand therapy, I've certainly seen quite a significant reduction in the amount of joint deformity that's presenting, and obviously that's as a result of the DMARDS coming out onto the market. And I think just from a generational perspective as well, I think we're a little more proactive and preemptive in our approach to receiving medical care and receiving treatment. When we do see it in clinical practice in hand therapy, we probably often see a little more finger-based deformities like a swan necking, which is like a zigzag deformity of the finger, boutonniere deformity, which basically goes the other way around. We might see a Z deformity in the actual thumb. And like some of the slides that we saw a little earlier, we might see the big knuckles, which we call the MCP joints, start to drift towards the little finger. So that can often affect function quite significantly, because obviously the joints are no longer aligned and in a anatomical direction. Also, quite importantly, and unfortunately, we can also see that there can often be other associated and indirect conditions from the disease pathology, such as trigger fingers and carpal tunnel syndrome, tenosynovitis. Sometimes we can actually see tendon ruptures as a result of disease activity causing joint destruction, and then we may have a little bit of a bearing on the actual tendon, and the tendon can rupture. And that can often be one of the main causes for a spontaneous or a sudden loss of movement that some of our patients may experience. So we can see that rheumatoid arthritis can have very long-standing impacts and quite broad impacts. So some of the areas that a hand therapist will generally assess in rheumatoid arthritis, there are a number of areas that we will assess, and these are generally pretty universal across most hand conditions. But I think particularly with rheumatoid arthritis, we would be looking at focusing on pain, deformity, and function. And of course, assessment is really important because we can obviously identify where the problems are, but it really serves as a useful baseline for later comparisons. So whether it be after treatment to see what our response to treatment has been, or if it's just to try and get a bit of a snapshot of where we are at the moment and looking at comparing in months or years down the track. In terms of our non-operative treatment for rheumatoid arthritis, most of our patients will come from non-operative treatment. So education is a really big part of what we do. So looking at joint protection and joint preservation advice. That's the advice where we are trying to reduce the amount of stress on the joints when we consider how small the joints of the hand are compared to, let's say, something like an elbow or a shoulder. It stands to reason that they're quite fragile and quite delicate. And of course, if we've got inflammation, we can certainly contribute to destruction of those joints if we're putting high loads through them. So looking at trying to use bigger joints to do a job, such as carrying bags through the forearm rather than the hand, or using more joints to do a job, whether it be using two hands. And that may even extend to things like assistive devices. So using things like, for instance, jar openers or L-shaped knives, where you're using more joints to do the job rather than less joints to do the job. Exercise, so strengthening and stretches, and studies have shown that there has been a positive correlation with strengthening exercises in particular. We're often focusing on stretches and maintaining movement, but strengthening does have a big role to play, and it's positively correlated to function. But just like most things, there is a bit of a Goldilocks principle there, where going out and buying a squeezy ball is not going to be the answer. That may aggravate things, but really looking at essentially the right amount of load that's not going to basically cause more aggravation of the joint. And using heat and cold therapy. So both of those can be used at different times, depending on whether we are chasing flexibility and pain relief, or whether we're looking at trying to reduce pain associated with inflammation. So both of those can be very useful. And of course, from the post-operative perspective, we see a lot of patients after surgery. So we work very closely with plastic and hand surgeons and wrist and hand surgeons who may perform a number of procedures, such as a joint replacement, a joint fusion, or even a soft tissue reconstruction. But we'll obviously look at very specific protocols when we are following those. So leading to splints, as I said earlier, this is probably one of the mainstays of our treatment. And they're probably one of the main interventions in the hand therapist's toolkit. And this applies in RA too, and they often feature with patients who present with rheumatoid arthritis. And just like any other treatment, splintage is often very much a very bespoke thing and a very individualized thing, and it really needs to consider, particularly with patients who've got RA, their presenting pathology, their pain and their dysfunction, and of course, the wishes and the intent of the individual involved. So what I may see as basically being a good intervention, the patient may say, no, I prefer to actually look at doing this and not doing that, and not having a splint for this long. So it is very much collaborative and very individualized. So splints can be used to either rest a joint or a set of joints due to pain. They can be used to stretch and move a joint or a muscle or a tendon unit. So, for example, stretching the tight joints of the fingers may be something that we may be trying to achieve. We may also use it to correct deformity. So, for example, in the deformities that I mentioned earlier, such as a swan necking, if that deformity can be corrected manually, we can often place the actual joints or set of joints into that position to allow more anatomically correct position. And of course, that's going to have a big impact on improving the functional movement and also the function of the patient. Finally, we can also use splints post-operatively. So patients who've had any corrective surgery, such as you can see in that bottom image there, that's an individual who's had a rupture of the index finger tendon and has gone into a very specific set of splints to rehabilitate her hand and wrist. So finally, putting it all together, what is the benefit of seeing a hand therapist? Well, we have lots to offer with specialised knowledge and skills. We offer very individualised care. We're very holistic in our approach to care. So if you think a hand therapist can be of assistance, I think the first place for anyone to look is the AHTA website, where you can find an accredited hand therapist close to you. And I often recommend my patients to, as a starting point, get on the Arthritis Australia website, where there's plenty of information on arthritis and how to manage in a range of day-to-day functions. So thank you.
Thank you very much, Nick, for that interesting presentation. Indeed, a big thank you to all our speakers. We're just going to spend a few minutes reviewing the questions that we've got. While we're doing that, I'd just like to say a big thank you to our wonderful community of donors at the Bionics Institute. We've got new, we've got old donors, we've got small donors, we've got large donors, and I'd like to say a special thank you to a number of people who are in the audience this morning who've been loyal to us for over 20 years. So thank you very much. I hope after what you've seen today, you have a start of an appreciation of the wonderful work that we do at the Bionics Institute, work that can have a really dramatic impact on patients' lives. And I hope that in the future, some of you will feel able to support our work, even in a modest way, to move this new device from the laboratory to clinical trials and then into clinics for helping to treat patients. So we'll be sending out our Christmas appeal in November, and the focus of that will be rheumatoid arthritis. And all the money that we raise in the appeal will help speed up our work, potentially allowing the implant to arrive within a couple of years, really to help transform patients' lives, people who are living with rheumatoid arthritis. So we have just time to answer some of your questions. James, I'd now like to hand over to you, please.
Thanks, Anne. Interestingly enough, one of the main questions that keeps coming up is related to what you just mentioned, which is when might that clinical trial start? Now, obviously, we would love to start that trial now, but obviously we're not quite ready to do that yet. We do anticipate currently that the trial probably would be ready in the next, that classical 3 to 5 years. However, it really is funding dependent, and we really do think that if we could have an injection of some funding, probably in the order of that, $6 to $7 million range, we could actually get this trial started within the next couple of years with that kind of injection. So again, just really highlighting how important that appeal you just mentioned was. So for those of you out there hanging out for the trial, we're working as quickly as we can, and only with your support can we make that go faster. Another question that's coming up quite often is related to one of the things you mentioned, Sophie. It's around, you said there's nerve controlled hunger and fullness as well. And so there's some questions around, does that mean when my device turns on, I'll start feeling hungry or full? Or, could you explain that a little bit more to us, please?
Sure. Yeah, that's a good question. Yeah, I mean, certainly the vagus nerve controls things like fullness and hunger, and also digestion. So the short answer is we haven't seen any of these changes in appetite or indeed, digestion, how often you poop, for example, in the clinical trials that have gone before. And so patients seem to eat regularly. They have no experience of feeling of change of appetite, and certainly digestion isn't affected. So it seems that when you stimulate this particular nerve, when you have a certain condition, it seems that the effects are related to the immune system.
Thanks, Sophie. Another question that's come up is a couple of questions for Nick. One is, could he just explain what a DMARDS is? And also, could he just explain a bit more about when heat therapy is used and when cold therapy is used, if that's possible?
That was for me, wasn't it, the question?
Sorry, Nick?
That was for me, was it? Yep.
Yep.
Yeah. Okay. The first question, I didn't quite get the first one, but the second one about heat and cold therapy.
DMARDS. What does that stand for?
Oh, DMARDS. They're the disease-modifying drugs that we had, that Evange Romas mentioned before. So, drugs like methotrexate and sulfasalazine. So, as I was saying in that slide, as a result of these particular drugs, we are seeing far less of it. So when I was training at university, we'd be making a lot of splints that were basically designed for very significant deformity. But since DMARDS have been sort of widely used, we've been finding that we're seeing a lot less of that. In relation to the question about hot and cold therapy, heat therapy generally, such as using a wax bath or hot water soak or a hot water bottle, anything that can get heat to the hands is often going to be useful because it basically helps to improve the flexibility of the actual of the joints. The synovial fluid tends to become less viscous, which means basically the joint can move a lot more easily. So along with that comes not just improved movement, but you also get less pain, which is obviously very, very important. When it comes to inflammatory conditions like rheumatoid arthritis, when people are having flare-ups, sometimes using cold therapy like a cold pack can often be useful. But I would probably say on average, I'll probably find that most of our patients, when their disease activity is very low, that heat is usually the more preferred method to try and get improved movement and reduce pain.
Great, thanks, Nick. And one final one I think we might be able to squeeze in for you, Sophie. This vagus nerve stimulation is meant to turn down that inflammatory pathway, but you mentioned it's actually also a really important pathway. So are we going to end up with a lack of inflammation around the body?
Yeah, well, look, that's a really good question. So as far as we know, vagal nerve stimulation acts really well when the immune system is flaring up. And when the immune system is, say, at regular normal levels, say when a patient with arthritis is not experiencing such intense inflammation, we do believe that the vagal nerve stimulation won't have such a pronounced effect, and certainly won't lower the immune system to be sort of below what it should be. I guess the analogy I always think of is when you take a Panadol for a headache, your headache goes away. When you take a Panadol without a headache, your brain doesn't go numb.
Great analogy, thanks, Sophie. And unfortunately, I think that's all the time for questions we're going to have. So if we didn't get to yours, we're sorry. We'll try and get to as many as we can after the event. I'll hand back to you now. Thanks, Anne.
Okay, thanks, James. And thank you to all our speakers, James Fallon, Sophie Payne, Evange Romas, and Nick Antoniou. So I hope you enjoyed this information session on rethinking rheumatoid arthritis. I hope it's given you food for thought. And I hope that you'll stay in touch with the Bionics Institute community and see how this work progresses. Thank you to all of you who provided addresses at registration. We'll be sending out jar openers to you very soon. Jar openers, like Nick mentioned, can be very helpful for those with hand issues. Thank you very much for joining us. Thank you for supporting us, and we look forward to staying in touch with you. Thank you. Goodbye.